ISB, oh pardon me, excuse me. Welcome to ISB's 5th annual Pecha Kucha event. This event started all those years back as a way to showcase the talent within our community, and is one of the events that I most look forward to every year. And this year it fits perfectly within the school's theme of in-house expertise. So double whammy, and it's twice as good this year. I cannot wait to hear the inspirational ideas that are going to be coming from tonight's sets of speakers. So without further ado, because you really do not want to hear to me, I would like to ask our first presenter to come up here. Thank you.
So I was told I'm given this slide to test my voice. Can you hear me? Yeah. Good. Closer?
Yeah.
All right. So now the game is... I have a glass of red wine underneath my seat. Good evening, everybody. My name is Giles, and I am a midwife. Thank you. What is a midwife? Is it a nurse? Is it a doula? Is she as safe as a doctor? Do they still exist? I mean, midwife Middle Ages, no? So, no, actually midwife comes from Old English with woman. And yes, they attended women's birth. The men did not get involved, except when they thought that midwives were witches, and so they burned them. Then men professionalized medicine and convinced everybody it was safer to give birth with a male attendant. Now we have about... midwives attend about 10% of births in America, and the rest are attended by obstetricians. And midwives attend births mostly in the hospital setting, not in women's homes. So this might explain partially explain why in obstetrics we have the American healthcare paradox. We spend more, but we achieve less. We have a higher infant and maternal mortality and morbidity rate than in comparable economically developed countries. Even though the majority of pregnancies and births are at low risk of complications, we view birth as a disease, and we see it as normal only in retrospect. Labor is very often induced, it is augmented. We ask women to be on their backs, and because the pain is too much, they take the epidural. And if it doesn't work, then we perform a C-section. In 1970, the C-section rate was 5%. It is today 32%, with no concomitant decrease in maternal and infant mortality rates. We also live in a litigious society, so we practice defensive medicine. It's costly and does not prioritize health. This is me. And I was very pregnant and we first arrived in New York. I was seeing a midwife in the UK and coming from France, using a midwife is the norm, so that's what I was looking for. In France and the UK are also countries with universal healthcare, so it makes sense, it's cost effective to use midwives as kind of primary care providers. So I chose to give birth at home because I was healthy and that's where I can best relax. I had a backup obstetrician and a backup hospital. And just to give you an idea, in the US, 1% of women give birth at home, and in the Netherlands, for example, 30% of women give birth at home. The care my midwife gave me was life-changing. She enabled me to find a strength that I never knew I had. So I quit my job in advertising and I decided I'm going to learn to help other women to find their own strength. So first I worked as a doula. This is a non-medical support person. She does emotional, physical and informational support. The midwife can do all of that, but really she's a medical provider and she's responsible for the health and safety of mom and baby. So I completed a Master's of Science in Midwifery. I learned everything about normal prenatal care, birth, postpartum, and normal gynecology. I also learned to see when there were risk factors and complications and to refer to obstetricians. Research shows that women attended by midwives are less likely to have interventions than a comparable group of women cared for by obstetrician. They also report a higher satisfaction rate. Why is that? Some call it low-tech, high-touch. Midwives spend longer during prenatal visits. They focus on health promotion. They spend time in the shared decision-making process. And they're more hands-on during birth. So everybody agrees we have to reduce unnecessary interventions. They're costly and do not favor health. In a hospital setting, there are currently C-section reducing quality initiatives. They all focus on supporting physiologic birth. It's a tall order because the hospitals are set up for interventions, not for normal. Now, what is physiologic birth? It's a birth that is powered by the innate human capacity of a woman and a baby. It is one that is mediated by a series of hormones. Midwives are currently working together in the state of New York with the Department of Health to open more midwife-led birth centers, which are places that favor physiologic birth. They are small, home-like settings and practices that support physiologic birth include freedom of movement, access to water, freedom to eat and drink, and invite as many people as you need for your birth. They also work collaboratively with hospitals should a transfer be needed. This is our mayor. He declared at the beginning of the year that New York City residents should all have universal access to healthcare. So opening more birth centers would allow more residents to have access to cost-effective care. It would also mean a higher satisfaction for women who are given a chance to find their own strength, and for midwives who can practice the physiological model of birth. Do we believe in a healthy and capable society? So let's ask for more midwives. Tell your